a lot of good lectures and information. Now this particular section, it will be a different one, a different type of presentation. We're going to start, and we're calling it as a panel discussions. Jasmine Ahmed, who is Dr. Jasmine Ahmed, is in clinic. She is working in the psychiatric department of the Larkin Hospital. She is going to present a clinical case. The clinical case that she will present, we as a panelist is going to dissect that and information. The process of diagnosis is going to be manifested into this particular case presentation, not the diagnostic itself. So that means our purpose is not to provide management and diagnosis of particularly this case. So it will be more, what else? You got it? What else? Why? What are the thought process? This is actually the model by which the clinical educations is necessary to put in. When we was doing this, why we have to do the sleep, we realized that there is a big gap in our educational model where we do not use the why rather than just give a lecture, okay? So that's what we are coming into. I hope everybody is come inside. Whoever is outside now, we're going to start. Now I'm going to invite Dr. Jasmine Ahmed to provide the clinical case. Thanks.
Good afternoon, almost good evening, everyone. I'm Dr. Ahmed, and I'm going to be presenting a clinical case here. And this case is going to be very multifactorial. It's going to be very, more like what you're going to see day to day. Patients don't come in textbook with a clear-cut diagnosis or a reason for a diagnosis. All right, so the main point will be sleep disorders. And the chief complaint is going to be, I'm not able to get enough sleep, and it's getting worse. So it's a 63-year-old white male. The patient has recently been falling asleep at work. The patient has a very high demand job, works at NASA, and lost his job 2 weeks ago. The sleep difficulty started 2 years ago, however, during his divorce, but now has recently become worse over the last 2 months. He describes a latency of 30 to 45 minutes, and he wakes up every hour or two, and sometimes it can last 15 minutes to more. On average, he was getting 4.5 hours of sleep for the last, 1.5, 2 years. However, it has shortened to 3.5 hours over the last 2 months. The patient now takes frequent daytime naps. He feels on edge, he's worried all the time. At night, at times he gets racing thoughts. Sometimes he wakes up and he has this sensation of choking, except this sensation has only started as of 4 weeks ago. He states that there's no change in seasonality with his sleep. His basic hygiene is good. He goes to sleep around the same time every night, wakes up at the same time, and does not bring work into the bedroom. So he also describes himself as a very type A personality. He denies any mood disturbance, and he also denies any of these hypnagogic, hypnopompic hallucinations right before waking up or going to sleep. He denies sleep paralysis. As far as his past medical history, he has quite a few here. He has hypertension for the last 20 years, treated on 3 hypertensive medications. The patient is obese with a BMI of 36 that has jumped by 2 points over the last 2 years. I don't know if it's a coincidence of his divorce or what, but He does have hypercholesterolemia, treated with statins, tension-type headaches, and COPD. Now, his COPD, he had an exacerbation about a year ago that required hospitalization with this patient. The patient has to drink several caffeinated beverages, according to him, about 3 to 4 a day to keep up with his work. Smokes tobacco, about half a pack a day for 30 years, and drinks alcoholic beverages. Now, this is subjective, as you know, you have to ask. 2 beers a night and more on weekends and at social events. He denies recreational drugs, however, does admit to over-the-counter use of sleep aids frequently. The patient does have a past psychiatric history of a major depressive episode with some perceptual disturbance. 2 years ago, treated with antipsychotic medication, currently no longer on medication. As far as the family history, the patient has a mother who's 86 years old and has history of insomnia, which is important here. Father who is 90 with a history of coronary artery disease. In the physical exam, most of it was within normal limits. However, there was 1+ edema in the lower extremities, some hyperresonance in both lung fields, and some mild wheezing. Also note there's some varicosities in the lower extremities. The patient did have a sleep study done 10 years ago, which came back negative. CBC is positive for anemia, and the vitals are normal except for an elevated pulse of 103. Urine toxicology is negative, and the patient has tried diphenhydramine and buspirone in the past. As far as the mental status, the appearance of the patient is well groomed, hygiene is well, the gait is good, and the posture is upright. The behavior is cooperative with proper eye contact. There was no psychomotor agitation noted. Speech was very fluid, normal rhythm, normal rate. Mood as per patient was okay but tired. Affect is congruent, euthymic, and with full range. Thought process was organized, linear, goal-oriented, and the thought content didn't include any psychotic, delusional, or suicidal thoughts. Insight and judgment was intact. His memory was good with a mini-mental score of 28 out of 30, concentration also intact. So what's keeping the patient awake? So multifactorial, complications of maybe chronic medical conditions. Maybe this is acute on chronic nuances sleep apnea, even though the sleep study was negative. That was 10 years ago. Patient has, over the last 2 years, increased 2 points in BMI. This could be the case. Patient also could be suffering from CHF at this point. Long history of COPD. Complications of psychiatric disorders. Patient has a significant history of major depressive disorder. Maybe this is maybe it's a reemergence of the psychiatric condition. The social habits of the patient include alcohol use, tobacco use, poor lifestyle choices that can affect sleep. The patient also has a lot of high type A personality and tends to work too much. So that can also affect our sleep hygiene. So now our panel is going to elaborate a little bit more on certain aspects of this case. And I'm just going to briefly say what they're going to be. So the medical conditions contributing to disordered sleep, insomnia and how it can impact psychiatric disorders, novel markers in sleep physiology, and wearable, technology for that, pharmacological interventions, and a little bit of the pathology behind insomnia. Thank you.
All right. Now I'm going to come down to the real world. Real world, this particular patient needs questioning. One of the things that is the patient is presented with the age, and it's a male. Now, immediately in family medicine practice, we can jump into a conclusions and make the diagnosis. The problem is, if we keep on doing it, we will not know what is the detailed history about choking. This particular patient has hypertension. Patient have choking. what do you mean by choking? Remember that we have to return back to the patient to clarifications. Now, in this case, the clarifications may be, choking is choking, or I can't breathe and I jump up from the bed, or I'm so much into shortness of breathing at that particular moment that nothing helps me other than drinking some water. Very practical way, the patient may say. That can indicate paroxysmal nocturnal dyspnea. What is pathognomic of the right heart failure? Paroxysmal nocturnal dyspnea. We may totally ignore that one if we only look at this case and get to the diagnosis. Now, once you have a patient who has paroxysmal nocturnal dyspnea, it is our responsibility to look at this patient. What we are looking, this patient's apparently in the daytime, perhaps there is no other features than the short neck, obesity, 37 BMI. That is significant. Now, this patient is a high risk. I'm going to put my stethoscope on this patient, and I'm going to identify, is this patient have a heart failure? What will be indicating for me to analyze his third heart sound? Because it is pathognomic. What I'm trying to say is that if it is a paroxysmal nocturnal dyspnea and you have third heart sound, you are definitely dealing with right heart failure. Now, you look at the jugular vein and it is distended. You want that patient to lie down. When the patient is lying down, you are pushing in the hepatic bed. And you are trying to find out if jugular vein has some kind of influx. If there is no influx, that is a solid tumor somewhere is sitting there causing a superior vena cava obstructions. But you see that there is continuity, but it is enlarged. That is the right heart failure. Who gets more right heart failure? Obstructive sleep apnea. Now, I am not trying to give a lecture, I'm trying to analyze this case. And when I'm going to look at the pulse, I'm going to figure it out if it is irregular. With all respect, most of the time we put a machine, in my office also, I'm also do the same thing. Blood pressure, pulse, respiration, everything automatic and comes in. Here is a clue. You put your finger on the pulse and it is regular. What are you thinking? It is regular? No. Put a stethoscope on the chest and now you check the pulse both simultaneously. You find out there is a deficit. What is happening? It is regularly irregular. When it is regularly irregular, am I dealing with arrhythmia? Or there is a gap between SA node and AV node. Impulse is now delayed. So you cannot identify that until you put a EKG. So I'm going to do the EKG. But I want to see what I'm looking into the EKG. The patient is only choking. You know, no insurance company can pay this, what is in back of our head, we're thinking. So you do the EKG and you said that, well, what I'm going to see in the EKG if there is a right ventricular hypertrophy? Then I'm going to look at the V1 to V6. And I look at the V1 to V6. And I don't know why I'm looking at the V1 to V6. Only I know that the EKG was invented when Ethnovan put his leg on the water. Remember? Ethnovan said that there is a triangle. That triangle is created by Ethnovan to analyze the EKG, where he said, and it is many, many years before, that you put a positive electrode into the surface of the body. If the vector of the heart is going towards that electrode, it will give a positive deflection. All right? If it is so, then look at that. Where is my positive electrodes are placed? It is in the left side. Left arms has positive. Left leg has positive. So now the vector is supposed to go this way because the heart is located in the left side, and this way. Dr. Ari Goldberg, you know Dr. Ari Goldberg wrote a very beautiful EKG book, only this much. Dr. Ari Goldberg, first time, he said that this 3 leads is not enough. I want to see the whole heart. That's why the augmented lead came. AVR, AVL, and AVF. But these are all limb leads, going back to my point. Then the V1 to V6 are all positive. So if that is true, that vector is going to go towards the positive pole, then V1 is located in the right side of the sternal border, at the 4th intercostal space. So the right side of the heart, if it is enlarged, I am going to see a deflections of the vector coming towards the right side. I will have a tall R. You see? But if it is a normal heart, a normal person, I will have the vector is going towards the left side, so V1 will have a small r, and V6 will be large R. That is called RR progressions. Little baby of the R is ultimately go to the bigger one. So if this is the case, 63 years old, I am doing the EKG and I see the tall R in V1 or V2. I will say, my thought is working. This patient have a right ventricular hypertrophy. But why this patient will have right ventricular hypertrophy? Remember that right atrium gets the blood from superior vena cava and inferior vena cava and ultimately comes to the right side. Right atrium gives the blood to the right ventricle and the right ventricle gives the blood to the lungs. The lung is already full or stiff or high pressure. What it will do, it will give the back pressure to the right ventricle. Right ventricle will give the pressure back to the right atrium. I will have a jugular vein distension. You follow me? So ultimately what really happening? This patient have choking or shortness of breathing. My panel is saying that, well, my God, if you give the lecture, we're going to talk what? Okay, I'm going to stop and then I will go back to them and then back to again. So what really happened is that your right side of the heart is actually as a parameters, it assesses, gives you information about the lungs. That's why many, many years before, when there is a lung volume is causing that, lung causing the heart to fail, we used to call pulmonale. Don't forget that. My God, we are all forgetting. Every time something happens, we are just referring. No. That days are over. Be a doctor, because the specialist is not going to help. I'm sorry, specialist is here, so they will help you, but your assessment has to be there, bedside. So ultimately what happens here, we have a patient who may have right-sided problem, and that right-sided problems, remember superior vena cava, where it ends, Next to it is your SA node. So SA node is going to give the impulse to ultimately provide that to AV node, and AV node to ultimately to the ventricles. So SA node is a big time impulse there with the parasympathetic. Keep in mind, if the SA node to AV node is 0.20 or more, you have a dissociation between the SA and AV. We are talking about first degree. If the first degree ultimately continue and somebody is drinking and smoking, all right? Somebody is taking drug. They say marijuana is not drug. Please, I don't understand this. I go there and come out. Okay? What is happening? Every drug that has been invented, means drug means street drugs. They are designed to use sympathetic. You understand? Sympathetic and parasympathetic, when they are clashing, remember sympathetic is the mother. Sympathetic is the mother. Mother means it provides, it is the dictations by the creator. You must have that one so that you can sustain life. Parasympathetic, other hand, is your emotions. A neighbor maybe, no, that's just okay. So bottom line is that when you are clashing that, you are exciting the other factors and you're causing a rapid successions of the heartbeat. Now, when that person is go into the sleep, that's why I was saying 1/3 of our life we don't know. The clinical picture is totally goes into the bizarre. That moment, the patient actually going down and dead. Okay? There is no impulses coming out. Remember that that's what all these 2 days we have learned. During that time, when there is a hypoxia, hypercapnia start high. So hypoxia causes what? A disharmony between the SA node and AV node. Atrial fibrillation starts because now the heart goes back and jump into. Look, the lectures after lectures, we know that it provides a abnormal slowing of the heart and that it increases that, right? And that is the moment you are going to create a sudden death conditions, all right? So 63 years old patient came in. Dr. Said is a professor of pharmacology and he's now here to talk about some of the medications that can be appropriate or how that works. Can you please?
Thank you, Dr. Ahmed. All right, so I work in the School of Pharmacy, and then all of us have heard excellent talk, especially Dr. Nawaz yesterday. So I'm not going to go into detailed pharmacology, but I've prepared this lecture from the perspective of a pharmacist. So I must make a disclaimer that some of these slides are borrowed from some of my colleagues who are expert in neuropharmacology, some of my own lecture notes, and some open source educational website. And I thought that that's prudent to have talk focused from the perspective of a pharmacist. So pharmacists take NAPLEX exam, it's National North American Pharmacy License Exam. So the drugs that are more commonly tested, I have included them in this talk. And then I like reading history, so I have actually put together some interesting facts. So hopefully that will keep you awake, and then we'll enjoy this lecture. So I like to always, go back to the basic definition. So we use sedative and hypnotics to address some of those sleep disorders. So sedative, it's a calming agent. It decreases the activity. Hypnotic agents facilitate sleep. And anxiolytic drugs, as the name indicates, will decrease the anxiety. Okay? So these effects are accomplished by several types of drugs that include CNS, depressant, non-benzodiazepine anxiolytics. Now they are a big focus of research nowadays. There are some other antidepressant and even beta blockers. So sedative hypnotics suppress CNS activity. They are pharmacologically diverse, and depending on the dose, the effect will go from calming to sleep to unconsciousness if you're not careful, especially the drugs that have a very narrow therapeutic window could cause coma and lead to ultimate death. So we have anxiolytics, hypnotics, anticonvulsant, muscle relaxant, anesthesia induction, and I'll go over as follows. So again, I will just quickly go over. We had a pretty nice discussion yesterday. So almost all hypnotics and sedatives work on GABA system. So gamma-aminobutyric acid is a natural inhibitory neurotransmitter in the CNS. Now, so it binds with GABA and then opens up the chloride channel and then results in all the pharmacological effect. Now, I'll come back to this slide, but just take a look really quickly right here. So it's a pentamer. It's a pretty large molecule. Where's the... Just looking for the laser. Oh, I'm sorry. Yeah. So it's a pentamer. It's a pretty large molecule. You will notice that now we have pretty decent understanding due to the advancement of molecular biology and X-ray crystallography. We actually have pinpointed where each drug binds. So Tulane University website, they actually maintain a pretty nice database on neuropharmacology and the drugs, their structure have been resolved, where they bind, how they elicit their pharmacological effect. So yesterday, I recall there was a question regarding the difference of mechanism between benzodiazepines and barbiturate. So benzodiazepines, they are allostatic modulator. They actually help GABA to bind strongly with the GABA receptor and elicit its pharmacological response. On the other hand, barbiturates are actual agonists. They actually enhances the effect of GABA significantly and keeps the chloride channel open. And then if you're not careful, that can lead to death. And this is the major reason why barbiturates are not very commonly prescribed and the benzodiazepines become more favorable. So again, as I mentioned, I like reading history. Again, we keep our pharmacy students entertained with some snippets from the history. So from centuries ago, still alcohol has been used as, sedative hypnotics if people have not become sensitive. And then opium, and then if you look at some, culture from Africa, they still use some alkaloids to induce, hypnosis. So the first, what I call a chemical substance that was, we knew very well was sodium bromide salt that was used as a, sedative in 1800. Then actually came chlorohydrate. That's actually a derivative of ethyl alcohol, drinking alcohol. Now, it actually has a very interesting history. So in 1903, there was a pub, a bar, and a restaurant in Chicago. The bartender name was Michael Finn, and he was called Mickey. So in that bar, they would actually look at the customer. If customer looks well affluent, they will slip some of those Mickey, and then the person will become unconscious. They will rob them and they'll dump the body in the alley. So this case was actually become very popular, and then Oxford Dictionary actually included that word in 1915. So chlorohydrate is actually also known as Mickey, Finn, or knockout drops. So I found that history to be very interesting. Then came paraaldehyde. So they were introduced in, they were made in 1880, and then they actually come up to the market, from 1890s, and they were used until 1903. Then came the barbitals. So again, they were prepared in 1864 with the advancement in chemistry. So the problem with the barbiturates were the safety, and then with slight overdose that can actually lead to death. And then eventually they were replaced with benzodiazepine. Now, the major victim of barbiturate overdose was Marilyn Monroe. She died in 1962 due to the overdose of barbiturate. And Rolling Stone actually wrote a song. It's called Mother's Little Helper. So I'm not going to sing you a song. I sing horribly. So, but these drugs were actually prescribed heavily to the women for, any common disorder. They were anxious. They were, feeling tired. They were just popping pill. So Rolling Stone wrote a song, and I'll just read you 2 lines, and you will see the mindset at that time. So mother needs something today to calm her down. And though she is not really ill, now this is important, and though she is not really ill, but there's a little yellow pill. So it was the mindset at the time that just pop a pill and feel better, pop a pill and feel better. And then, that actually killed Marilyn Monroe. I mean, you can imagine she was a celebrity and then, dealing with some psychological issues, and then she just overdosed and then died of barbiturate toxicity. So barbiturates today, we still use phenobarbital, use an anticonvulsant. So now we have some ultra-short acting, newly synthesized barbiturates for, anesthesia induction. Also, we can find a barbiturate called butalbital and furinol, Furoset, and Esgic. It's a combination of 3 drugs, butalbital with aspirin or acetaminophen as an analgesic and caffeine as well as a stimulant. Now, Furoset, number 3, has actually codeine in it. It's a controlled substance, and then, still is in use today. Then in 1950s, a major anti-anxiolytic or tranquilizer was introduced called mepobromate. So again, you notice that when I was looking for some information, I noticed very unusual, very interesting actually pamphlet that were published and they were marketed to the women all again. So this drug is called Miltown. So housewives across the nation actually quoted from the newspaper that were being prescribed Miltown for insomnia, anxiety, and emotional upsets. And there was even a poster that says menopause doesn't need to be depressive. So for almost any condition, they were just selling Miltown left and right. And then came the benzodiazepine. So the first benzodiazepine was brought to the market in 1957, called Librium. It had hypnotic and sedative effect, worked very well. It was less toxic, and if you notice that it says that more accessible and communicative. So it will not knock a person off. Person will still be able to keep their function. So it has superior efficacy and safety, and then they become hypnotics of choice. So and then came Valium in 1963, and I must tell you that my mother even used azepam. I mean, it's being used sometimes. So there was actually a movie made by the movie called I'm Dancing as Fast as I Can. So again, benzodiazepine have issue with habit formation. So Barbara Gordon, she's actually an Emmy Award-winning documentary filmmaker. She actually herself suffered from the addiction and a problem with weaning off from the Valium. So this actually a pretty interesting movie. Actually, my professor showed me during our pharmacology class. And I'm going to shamelessly market my book. So I wrote this book, Social Aspects of Drug Discovery, Development, and Commercialization. We wrote a whole chapter on the tactics that pharmaceutical industry use to market the drug. So you notice that those interesting pamphlets are telling women, take this drug for this, and then pill become just like candy. Even today, if you watch the commercial, you will notice that as the healthcare provider, if this drug is right for you. And then the patient will expect that physician will prescribe that drug, not realizing that patient has looked at the whole person, there are other problems, that drug might not be suitable. And if patient doesn't write that prescription, patient will think that the doctors are not doing their job. So I actually wrote a whole chapter in my book talking about ethics of marketing the drug to the patient. So the PAMs, benzodiazepines, there are hundreds of them out there. And if you look at Pharmacology Journal, you will notice that there are tons of synthetic benzodiazepines in the market, in research phase. And then 14 are in the US market. I checked the day before yesterday, and this is the most up-to-date list. So the drugs that are in those signed, they are actually no longer sold as branded. Now they are off patent, and you can buy them from generic sources. So then we have now new drugs. We call them Z drugs, as we heard yesterday as well. So they have replaced, benzodiazepines. They are safe. They're short-acting. They are usually non-habit forming. They have very similar effect. They have different binding sites on GABA site. But then, as I said, they tend to be, not habit forming and, rather much safer. I think that pretty much ends my talk. I think we can take question and answer in the panel setting.
Again, we are still into the process of analyzing the case. We learned some of the medications now, but what is the next step on this patient? What about if this patient is not needed any medications, interventions because of the psychiatric conditions? It may be something to do with the patients with the COPD. This patient is a smoker. Okay? Now, if the patient has a COPD or patient have asthma, I'm just saying that both. One is the obstructive airway disease, another is the fibrosis of the lungs. Pathology is completely different, but the end results in case of this particular case is going to be 83% risk of that, because we learned from the last 2 days that how it becomes a very complicated issue when somebody has respiratory problems on the top of the sleep apnea. This particular patient is going to go to the sleep study, definitely, okay? But don't forget to analyze the lungs. Now, when we are going to do the lung study, we have to know the spirometry. You know, basic spirometry, if we don't know analyzing, then we will not be proceed forward, okay? One of them is that just a complete normal stethoscope examinations on this patient. Normal breathing of a person is there should be, inspiratory sound will be prolonged, then expiratory sound should be quicker, okay? So inspiratory sound and expiratory sound, if your ear is not going to analyze that properly, you will not be able to figure it out that the patient have equal or prolonged expiratory sound, which indicates the patient have obstructions in the airway. Not wheezing, okay? Wheezing is not, all wheezers are not asthma, okay? Remember that? So you don't wait for the wheezing, you check the expiratory sound. In this patient, expiratory sound is prolonged. So this patient have some kind of fibrosis or some kind of obstructions, all right? Now, that obstructions cannot be analyzed by X-ray. Because that depends on what will be the characters. Remember that in the 2 days lecture, we learned that there is a, if you give the challenge of medications, what is it called? The category, yes, if we do methacholine in the sleep deprived patients, it may not be exactly the same. These are good news and information that we got it. So methacholine challenge is not going to be equal like the way normally for obstructive airway disease will provide. So now going back to all this thing, because we have to analyze the case rather than just clear that this is what is going on with the patient. Next panelist is going to talk about the relations of the heart and the lungs. He has given the lecture before, but now maybe in a short about this particular case. If you can analyze a little bit, Dr. That will be.
From the physiological perspective, in the field of behavioral cardiovascular medicine, psychocardiology, we have to look at how psychological risk factors, they can basically affect the cardiovascular system. In this particular case, later on we're going to go into the psychiatric portion, might be that when you're asking yourself the question of why this patient is waking up at night, you have to look into the hemodynamic or physiological perspective. Is because he cannot breathe or he's thinking about what happened during the day. Maybe he's ruminating. It's a psychological reason behind his waking up, or his cycles are affected, or there's some kind of physiological reason that it's affecting the heart and the lungs. So how you monitor that? Well, in terms of psychological risk factors, we have various scales or constructs that we can follow, including anxiety, like STAT, trait anxiety, anger, depressive symptomatology, and so forth. From the more electrophysiological perspective, into heart rate variability, we can look at diurnal variations in the oscillations of the autonomic functioning. So what you want to see is that these variations come and go. Probably this patient will have less variation throughout the day in 24 hours or throughout a week. So as we move that patient into the management and the process of treatment, we want to see that those variations, diurnal variations, start to gain an amplitude. That can be monitored using various devices. One simple example could be using a BioPatch. Probably it's a device around this size, and it attaches ECG electrodes, and you can simultaneously monitor ECGs plus respiratory rates. The other aspect from the physiological perspective to take into consideration, if the patient has these sleep disturbances and have the history of hypertension and other pulmonary system involvement, I would like to take a look at the subendocardial variability ratio as a novel marker, which is a marker of coronary perfusion. Those variations during 24-hour cycles are very important to be considered. And lastly, also the patient, him or herself, in this case him, can look into a more sensitive way to do journaling. So for the most part, in the last years, we've been giving paper, and the patient has to report, well, I ate today, I went to the market and I ate 2 sandwiches. And that night, that patient slept well. So you can start doing some kind of associations. Now we have tracking devices that we define for specific outcomes. That's to say, in this particular case, I'm sleeping good, I'm not sleeping good. And then you can track using a keychain and an app basically what kind of activities you're doing throughout the day. This is in the perspective of psychological risks. In the perspective of diet or lifestyles, you can also add those into the built-in into the app. So in that way, the patient can also, when it comes back to the clinic, can have a report that can show to their physician and say, you know what, probably part of the reason you're not sleeping well is that you're eating too much of these kind of nutrients that probably is an allergy, probably it's something that is causing inflammation to the airways. And a very good way to depict that, or basically to tease out what is causing that, is journaling. And we have electronic ways to do that these days.
Well, this is definitely gives some information that this particular case can go into long discussions, but we know that our time is limited. So we are going to do the sleep study on this patient, and this patient has sleep apnea by the assessment of the sleep study. But what I'm trying to put into the thoughts in everybody's mind is that this patient can be only having sleep apnea, but there may be underlying cause, and those underlying cause has to be investigated. Now, the patient may have sleep apnea, but patient also have tremendous another components, which is actually in this particular case, the patient have a restless leg syndrome. And also the patient looks like this patient may have some kind of anxiety underlying. So we wanted to know about restless leg syndromes and how we going to get into that one. It will be briefly discussed by the Dr. Said. And Dr. Marcos adequately talked about the parameters that we will look into that. But it is also very important to know that you don't have to have an invasive procedure to analyze somebody's pulse pressure. You don't have to have an invasive procedure to figure it out what is the patient's cardiac output is. You understand? Why? Because your physical examinations can provide that with the proper pulse ox and also with the ability to do if there is a pulsus paradoxus going on or not. Pulsus paradoxus is not easy to be assessed. It has to be by the blood pressure. Remember, it is pulse, but it's pulsus paradoxus. So if there is a pulsus paradoxus is going on, you can assess that by your own physical examinations technique. I'm sure you know about that. If there is a compensatory mechanisms is going on, you will be able to assess that at the bedside. And next things briefly, we must know about restless syndromes because this is a new things, and then it will be done by Dr. Said, and I will not intervene. After that, I will ask the main person who is going to conclude that it is a anxiety. What is the take-home lessons about the anxiety disorder as well?
So I also want to apologize about the slides that you have in your handout. So actually there was a little miscommunication, misunderstanding on my part, what I'm going to talk about. So, I have those slides. If you would like, I'll be more than happy to email them to you. So we'll talk about restless leg syndrome. Let's see, how do I do the presentation? Oh, right there. Okay. All right, so again, I'll mention that my mother suffered both from restless leg syndrome as well as insomnia. So again, this topic is very heavily tested for the pharmacist NAPLEX exam. So again, we ponder a lot on this topic. So again, I would start with some brief history. So this term of restless leg syndrome was coined by Carl Ekman, and then it's considered as a sensory motor symptom, and then they're usually felt during the wake state. And then this was described, a long time ago by English physicist, physician Thomas Willis in 1672. So Ekman actually did the epidemiological study, and then he concluded before 95, it's like 5% of the population has disorder. But recent studies shown that about 5 to 15% of the Caucasian population do suffer from this. And last night, actually, I checked at National Institute of Mental Disorder, and they mentioned about 7 to 10% of the American population do suffer from restless leg syndrome. Dr. Lourdes touched upon this a little while ago. So iron deficiency has been noted in almost every patient that has restless leg syndrome, except for a few exceptions. So, and then studies have shown, there's a reduced iron level in CSF. And then if you look at the MRI, the section of the brain, putamen and substantia nigra, which show lower, iron level. It was an interesting study published by Buragro et al. In 2002. They noticed that the patient who actually were going through restless leg syndrome, if you draw the blood, you will notice that there's a 50% reduction of free iron in the blood. So that actually, it's a pretty interesting topic, if you look at Pharmacology Journal. Still, why iron deficiency is causing restless leg syndrome is still being studied. We don't have definite answer, but it's a highly, investigated area. So also during pregnancy, about 11 to 27% of the female will experience RLS, and this will go away by itself without any intervention after giving birth. About 20 to 50% of the dialysis patient will also suffer from restless leg syndrome. And then people who have hypothyroidism and diabetes will also sometimes complain of RLS. And RLS has been also noticed with patient in rheumatoid arthritis and suffering from Sjögren's syndrome. So again, as I mentioned, we don't know exactly what causes it, but the current literature actually points to the malfunctioning of hypothalamic A1 dopamine cell. So what happens is their job is to actually modulate the dorsal raphe nucleus. The A1 cell actually project caudally towards the dorsal raphe nucleus and then inhibit their activity. Now, if those cells are gone or not functioning properly, then we have enhanced sensation and urge to move. So how do we diagnose RLS? A patient will have urge to move limbs, and then associated with para and then dysesthesia, and usually symptoms worse exclusively present at rest, and then sometimes patient will get up and walk and they will feel better, and then symptoms usually become worse at nighttime. And these patients will respond very well to dopaminergic drug like levodopa, and then they have periodic limb movement during sleep, and they often have positive family history as well. So again, Dr. Loris touched upon it. So again, I'm just enjoying. I was enjoying listening to her talk. So if you look at the survey, what patient will describe, they will say that I feel like electric current going through my legs. Like I feel like my legs are going crazy. I was like soda is bubbling or Coca-Cola is bubbling through my veins, aching in my bones, and somebody's pulling my legs, and then I feel like tearing. Sometimes these symptoms are pretty strong, feeling like throbbing and creepy crawly, like Dr. Loris showed. That a child draw a picture of ants crawling on the leg, and then growing pains and itching bones. So these are all the terms that patients have used to describe their restless leg syndrome. So how do we treat restless leg syndrome? That depends on exact physiology. So patients who have iron deficiency, giving them iron supplements does help. And then sometimes, just before they go to bed, a light activity. Now, you don't want to work out heavily, then, that will just wake you up. So light walking, brisk walking, stretching, taking cold or hot bath, depending on person. And then, not drinking coffee, actually, or stimulant. And then, as I mentioned, levodopa actually, does very well with patients suffering from RLS. But then levodopa causes, augmentation and then aggressive behavior in some patients. In some cases, opioids have also been used, and as I mentioned, iron supplement does help. And I was looking at National Institute of Complementary and Alternative Medicine. Surprisingly, patients with RLS do very well with St. John's wort, but you got to be careful with St. John's wort that induces enzyme. If you're taking other medication, you got to be careful with that. So I'm just going to stop right here. I mean, I had a whole talk on a lot of sleep disorders, so I don't want to make this full-blown lecture, but if you have any question, I'll be more than happy to delve into other disorders as well.
Okay, so we are, because of the time, we are going to go into that the components of the psychiatric elements, but one of the most important one here is that Dr. Gerald will be able to shed some light on this particular patient's anxiety-related disorder.
Hello. Hi. Okay, so here again, like Dr. I was saying, he was mentioning a presentation on the sedative hypnotics. I talked about it on my previous lecture. And you see, this is very important because of the fact of what this patient is going through, okay? We see them sometimes as the Antichrist, but in reality, we see choking. The patient is choking. We don't know why. It's being evaluated by the primary care physician. But it's one of the symptoms of anxiety, right? Being that said, you have a patient in front of you. This patient comes to me, I have to see the whole perspective. This is something new, something that has recently started. Now we know certain things about the patient, restless leg syndrome, a possible, fibrosis or hypertension on the lungs, which is causing the right side of the heart, strain, being hypertrophy, whatever not. And you have this individual in front of you who has very bad lifestyle behaviors. This individual smokes, this individual drinks, which are substances that will predispose to insomnia, predispose to anxiety disorders, and all whatnot. But at the same time, this behavior is one which, with the obesity, he has a history of COPD, smoking. This individual is probably also maybe having some reflux, causing aspiration, causing fibrosis to the lungs, and it becomes very challenging to treat, okay? And whatever or not is happening there causing his symptoms, you might say, okay, let's go for the benign thing, let's go for a trazodone, let's go for mirtazapine. Well, mirtazapine will alleviate if he's having any GERD, symptoms or whatnot, but, it could contribute to the obesity, At the same time, a trazodone or any anticholinergic, which you might think is pretty benign, is going to cause that cellular node to be affected. You know, you have prolonged prolongation of the QT. You could predispose to sudden death that Dr. Ahmed was talking about just with your benign little Benadryl. Okay? So, you know, basically he was taking even Buspar. The good thing about Buspar is that increased the respiratory center in the hindbrain, you know, the reaction to CO2, which he's having a lack of because it's respiratory problems, but at the same time can cause insomnia. You know, this is a very difficult patient you have to treat as a whole. You know, the restless leg syndrome, why is he had anemia. Why is he having anemia, right? At this age, he's a man. You know, then let's look for that. If he's having reflux, if he's, you know, if he's having tears, because he drinks, you know, lower GI bleed. What's going on here? How's his kidneys? Well, this is being, you know, all treated, and we're looking, you know, to get to the bottom line of it. At the end, this patient had a previous episode of major depressive disorder, and is at risk of developing, you know, psychiatric disorder again. If it's anxious, you know, type A personality, stressful job, you know, of getting more anxious and totally decompensating. And the reality is that while these things, you know, are being addressed by the PCP, you know, and at the same time, you know, we are, you know, trying to have the patient with lifestyle modifications, he needs to sleep. And the safest thing to put at this time, if we're not getting symptoms of depression, which we didn't, total depression, but there's some a little bit of anxiety component there, is to put the patient to sleep. A sedative, a hypnotic will be pretty safe, okay, in the short term, while other things are being addressed, because in treating this type of patient, most, you know, needs a multidisciplinary team, okay? So I think that, you know, treating the insomnia per se, we're going to decrease any anxiety, treating it with a hypnotic, even, for example, an Ativan, little dose of Ativan will protect the heart, decrease the blood pressure, okay, versus other things that might precipitate that, a C drug, you know, just initiating sleep, you know, short-term, short half-life one, or something like Lunesta, you know, long half-life, but will help the patient to sleep, you know, and while the restless leg syndrome is being addressed, you know, the patient can rest and not continue to have frequent awakenings throughout the night. That's what I think.
Well, this is a clinical case without any end. So it is not the destination that I was looking for. I was looking for the process. And I think my, not including me, other than me, my panel did an excellent job. Please give the round of applause. Now the question answer. If you have any question, please come forward and let me see who actually you are addressing to, and we will try to answer that. Any question? All right. If there is no more questions, one more time. Oh, go ahead.
Yes, I am. I'm sorry. Dr. Farrar, do you find that patients who have Asperger's have sleep difficulties and or mental difficulties that you need to do different anxiolytics for? I mean, I have a few patients, they gravitate to me, I guess, and they have multitude of problems. And I've thought sometimes that they might have sleep disorders, but I never pursued it. So now I'm wondering, in your experience, have you seen any of that?
Yeah, for sure. As you know, previous presentation with the pediatrician, somebody with Asperger, okay, autism spectrum disorder. All of these psychiatric disorders, you know, intellectual disabilities, you know, they come in a cluster of disorders. It's not just one. You don't say, is this? So a lot of them have ADHD, which is, I mean, when I was seeing the previous presentation, it's something that highly predisposes even infants to insomnia. okay? Some of them have comorbid bipolar disorder or some type of mood dysregulation disorder, okay? Anxiety disorders, there's a lot of anxieties that they have. Basically, yes, it is, a disorder like we were saying before, in autism spectrum that, they're going to have some type of distorted circadian rhythm and cycle, and it's hard to treat. Sometimes, it's just a minor thing, and you can use the melatonin, which is lacking, and it helps. But sometimes you need a little bit more, and sometimes you need to address the anxiety that the patient is having, because that's what it differentiates. Is it, just that the patient can fall asleep because there is an embedded problem in the brain, or is it that the patient is so anxious? And that's why sometimes you give an anxiolytic, which is not a strong hypnotic, and the patient sleeps. And, I've been sleeping with that, with a little bit of volume. It's because it was the anxiety that was causing them not to sleep. Sometimes you need multiple, because sometimes there's this regulation, of making that melatonin because of the patient, of cerebral palsy, somebody that had a hemorrhage and, is a young kid and has cerebral palsy, and it's not responding to a light, stimulus, all of that, and you might need a Lunesta, guanfacine, and on top of that, a sedative, to try to calm that patient down and then go to sleep.
Any other questions? Thank you, Dr. Jasmine Ahmed, Dr. Saeed Rizvi, the Associate Professor of the Hampton University, Virginia, and Dr. Gerald Ferrer from the Larkin Hospital, Program Director in the Psychiatry Department, and Dr. Marcos Sanchez as a Vice President and the Research Director of the Larkin Hospital, Academic Affairs. Thank you, all of you who listened to.